Good afternoon and welcome to Orlando. We just left a special clinical science series discussing prevention for coronary artery disease risk factors. I'm Dr. Donna Arnett, past president of the American Heart Association, and I'm here with two panelists to discuss these.
I'm Christie Ballantyne from Baylor College of Medicine in Houston, Texas.
My name is Marc. I'm a cardiac surgeon from Ottawa, Canada.
So Christie, we heard some follow-up today from the ACCORD study called Accordion. Why don't you tell us about that study and the findings?
Well, in the ACCORD study, there were two sub-studies. So the primary study was looking at intensive glycemic control versus the more usual care, less intensive. As you know, there was a lipid component where they did the combination of statin and fibrate. And there was also more intensive blood pressure control. And a lot of focus on this because the big news out of Sprint, going to less than 120, the results in the ACCORD, so the blood pressure study, sub-study was the Accordion, what was presented was a long-term follow-up. So during the study, there were trends towards favorable benefit in terms of blood pressure reduction. At the time it was presented, we were not quite as excited because they didn't hit a lot of the p-values for it. This was the long-term follow-up, and the major impact during the study was stroke reduction. In the long-term follow-up, what you could see is the blood pressure difference between groups narrowed, and you see the stroke benefit was lost. The interpretation of Bill Cushman shows that, in fact, most likely that was real because you had to have the blood pressure gradient to really see the stroke reduction, and I think that makes sense for it. There was still this interaction, though, that showed up, is that the people who got tight glycemic control didn't seem to have as much benefit from tight blood pressure control. One of the most interesting parts of it was the discussion by George Bacris, where he actually showed the data where if you line up the ACCORD blood pressure with Sprint, there's this caveat that Sprint did not include diabetics, but if you line it up, ACCORD was smaller, they were smaller numbers, but the confidence intervals for the point estimates were actually in the same trend for benefit. And it looks to me that in general, there is data to support that, in fact, intensive blood pressure control in diabetics, we don't have to necessarily treat them differently than we would see from the Sprint study. The other aspect of it was this interaction with the type diabetes control. So there wasn't any harm, there just wasn't additional benefit. So you wouldn't be hurting somebody, you might not be getting as much benefit in the tightly controlled diabetic as in the person with less tight control. So I think there was at least helping me to kind of piece together these two important trials that perhaps the data is more concordant than I thought.
So the bottom line is we still need to be treating our diabetics to a good blood pressure lowering goal.
Correct.
And that lines up with what was found in Sprint among non-diabetics yesterday. Yes. All right, terrific. So Marc, tell us about this new revascularization study that showed benefit of CABG in diabetic and multivessel disease patients.
For sure, Donna. This was an interesting study, not because it was observational. There have been a number of observational series that have looked at revascularization means either in diabetic patients or non-diabetics. In this case, it was in diabetic patients. And the number of patients was about 4,000 patients, if you will. But what was particularly unique about the study is that it included a lot of acute coronary syndrome patients. And typically, if you look at our main trials that kind of guide therapy right now in multivessel coronary disease patients, either diabetic or not, essentially Syntax and Freedom, there were maybe up to 30% or so of patients who had acute coronary syndromes. So in this particular population-based observational study held in British Columbia, which is one of the provinces of Canada and which has a single-payer system, therefore very good follow-up to 5 years because of their provincial database, we were able to look at about 63% of those patients who actually had an acute coronary syndrome. So for the first time, not only were there a lot of ACS patients, but also some power to look at whether any interaction existed between the outcomes of either PCI versus CABG and the fact that a patient may or may not have had an acute coronary syndrome. So essentially, the story was interesting. As we know, acute coronary syndrome with regards to multivessel disease plus or minus diabetic status has always been kind of the uncharted territory, if you will. And there's always very compelling dilemma regarding should we treat the culprit lesion or what's perceived to be the culprit lesion, or should we apply therapy for a given patient according to what the more stable coronary disease randomized trials give us, namely syntax freedom and others. So in this population-based study, essentially what it showed is that the acute coronary syndrome essentially made no difference. There was an advantage in favor of CABG over PCI, whether or not the patient was coming from an acute coronary syndrome type of situation. Obviously not STEMI, not ST elevation myocardial infarction, but non-STEMI acute coronary syndrome. So I think for the first time we have some data now telling us maybe not the full answer. I think it certainly doesn't give us the definitive answer that we should stop looking at the culprit lesion and send the patient to surgery. I think that's not the point of the trial. But even the recent ESC guidelines were suggesting, and certainly there was a feature accompanying the guidelines saying that, for instance, a patient with acute coronary syndrome, one could be forgiven for going straight with PCI for the culprit lesion and not even entertaining a heart team discussion. So I think in light of what we've heard today at the HA Scientific Sessions, we can probably put that aside and say that there's certainly good credence to give recommendation to a heart team discussion, even in the face of an acute coronary syndrome.
So the caveats, this was observational,
Of course,
right?
yeah.
And so it builds on what we know from Freedom in terms of the benefit of CABG for diabetic and stable coronary disease.
Yeah.
But we really still need to answer that piece about ACS in a randomized setting.
And I would say, Donna, there were a number of oddities in the trial. Not in the trial. Again, we tend to always think of trials. It was an population-based observational study. So the PCI patients were older. They had more often depressed LV function. They were more often of female gender. And they were more often urgent. The counterpart to this is that the coronary patients, the CABG patients, had more severe coronary disease. They more often had triple vessel disease. But there were a number of oddities. These were accounted for, and the team, I think, did a great job of trying to account for these factors in the survival analysis. Yet it came out, for instance, that the stroke rate in PCI patients was significantly much higher than in the CABG patients. So you would think that unless there's a vascular hypothesis behind it, or perhaps maybe the stroke could have been related to repeat revascularization and procedures and going through the arch and dislodging something, but obviously they do not have this mechanistic insight as to why the strokes happen. So that would kind of steer you, despite myself being a surgeon and certainly being very much in favor of surgery. I truly believe that it's the best thing that can be given to a patient with advanced coronary disease. But realizing that there might be a potential for indication, selection, and perhaps even adjudication bias against the PCI patient. So food for thought, but certainly not a definitive answer.
Yeah, that's why randomization is such a great tool.
Absolutely.
Yes. So Christie, there was a follow-up too today from the Jupiter trial. Thank you. So tell us about the Jupiter follow-up trial.
So this is a post-hoc analysis, but looked at a very relevant clinical question. When we treat a patient, even with a very effective therapy, their response to that therapy is variable. And one of the questions that we have is, when would you consider adding a second therapy? We've got multiple choices available now. And it was a very vague part of the guidelines. So what was done, that the European and Canadian guidelines, and in fact, even the most recent ACC-AHA guidelines, recommend that in high-risk patients that we choose statins based upon the usual response to therapy, and basically a highly effective statin in general gives a 50% reduction. Well, Jupiter used rosuvastatin at 20 milligrams, which is one of the dosages that's in our guidelines. And what he did was waterfall plots, and you could see that breaking it down as the people who had a 50% or more reduction in LDL, people who had 50 to 30, and there were people actually who had no reduction. So if you break it down into the different responses, what he saw is that the risk was related to the people who, not that surprisingly, the people who had the best response to therapy, over 50% LDL reduction, also had the lowest event rate. So they had the greatest relative risk reduction. And he showed this for LDL cholesterol and non-HDL cholesterol and ApoB. The numbers were a little bit different depending upon which surrogate you use for atherogenic particles. But I think it's more data in terms of, as a clinician, when we treat patients, and we always talk about evidence-based medicine, but we also talk about personalized therapy. And we all know that not everyone has the same response to a therapy. So how do we decide, okay, this person's had a very good response, I don't need to do anything else. This person didn't respond as well, perhaps something else would help. And I think he's done this before where they looked at the LDL levels on therapy. If you had a low LDL and low CRP, a lower event rate. So, but I think we might consider perhaps, are there some thresholds that we could consider? You treat somebody, they didn't drop their LDL by a certain percentage, they didn't get to a certain level. Would we now consider adding a second therapy? And this was, obviously, even if it's post hoc analyses, data out of clinical trials might still be helpful and informative. So I thought it was interesting. We face this issue now because when the guidelines came out, we had no evidence about therapies being added, reducing events. We've had one trial in Prove It that shows this, and there's some other big ones in progress now with the new class of agents, the PCSK9 inhibitors.
Well, certainly, as a pharmacogenetics person myself, I'm really curious about why there's such variability in even great drugs like rosuvastatin.
Yes.
And I think that's food for thought for our future too.
Well, and he's shown that in fact there are genetic variants associated with better, worse response in that for it. So it's in addition to compliance and maybe some other factors that your genes do influence it, and we do know that people have different response to therapy. So I think moving towards the future, when do we add that second therapy? And this is interesting data.
Well, Christie and Marc, another great session from Scientific Sessions. Thank you for listening.